At the outset, I would like to thank the President, Dr. Ramakrishnan, and all the office bearers and the coordinators of the CME for inviting us for this wonderful teaching program. And we are you're honored by your invitation. I'll straight away go into the topic per se. I have this conversation with Dr. Raman, and he suggested that this topic, let it be more of clinical. And again, the research hasn't reached the threshold of giving enough evidences on various areas as such at this point of time. So I would like to keep it clinical. Introduce it, the clinical description and the diagnosis, as Dr. Vidhu Kumar had pointed out, it's quite questionable. When we trace the history back into this whole internet addiction concept, it started with Dr. Ivan Goldberg, who in I think 1995, just before Kimberly Young started the work, he was a critic of DSM-4 and the diagnostic criteria which DSM-4 had brought in. So what he did is he had concocted on the basis of substance use disorder. He has concocted a disorder called internet addiction, and he wanted to it's a critique of the whole DSM-4 criteria per se. And he had put it in the, I think it's called psycom.net. I think that's not available at this point of time. It was a blog which he had created and he had put in over there. Like, to his surprise, he had received so many response that people are talking about their agony and their difficulties because of excessive usage of internet and uncontrolled usage of gadgets as such. Like, so it was interesting to see how to start with itself an atheoretical borrowing of the diagnostic criteria for substance use, and then employ that for internet addiction. That has started the whole debate about what is the validity of this whole diagnosis per se, because it's atheoretical and we don't have anything specifically created for this disorder itself. It is more borrowed from the substance use disorder per se. And there were people who had built up their CV a lot with researchers on this area, just conducting just giving screening instruments and conducting research on this in terms of prevalence in various areas. But there are specific timelines in which things have happened in favor of internet addiction. Some of the diagnostic criteria in terms of behavioral addiction and internet gaming disorder has happened at a later point of time. We'll come to it. But the question which Dr. Vidhu Kumar asked, the reason why it didn't take off is because of the reason of that the evidences to start with were anecdotal, and it's an theoretical approach, and there is no proper diagnostic criteria which was specific for internet addiction. The other most important thing is most of them had comorbid other psychiatric disorders too. Almost to the extent, if I had I had met with one of the South Korean researcher in terms of internet addiction. They do most of the research, and their problem seems to be very high when compared to us. And even in their population also, they are saying 60 to 70% of internet addiction disorder do have a comorbid other diagnosis too. So whether it is primary or secondary, whether it is a coping mechanism or it is a separate disorder, this debate is going on. If people are interested, I would suggest one reference material. This is a very beautifully written editorial which is called as "Are We Over Pathologizing Everyday Life?" This was done by Joseph Billiou in Journal of Behavioral Addiction in 2015. And that article was supplemented by commentaries by almost around 10 luminaries in the field of addiction and related area who had work for and against this whole concept of behavioral addiction per se. And it's a wonderful thing to read, because we understand how people look at it and how things have developed. So to start with, the clinical description itself is questionable. Second, the available evidence specifically towards the assessment and the treatment is not a good guide for us to go over. And but the issue is there are a lot of people who approach us with this as a problem. So what are we to do? That's a question which we always get into. So I'll start with the models of care as such. As in substance use disorder, here also the models of care move from complete abstinence to harm reduction. Complete abstinence is being pushed over here also, and one of the complete abstinence model which is being employed in China is this is General Taoran, who runs the boot camp, military boot camp approach in China, and which is basically to discipline people, and that's how he touts that things work better in China. And their problems are significant, and they put in a lot of restrictions on the whole internet usage by younger people as such. This is their approach, but that approach is not very conducive for the population whom we are facing, and the way in which internet is developing on an everyday basis, and it is getting into everyday life of us. especially we realized in the COVID times. It has taken over most of our life's activities per se. So everybody wants a digital interaction. How do we live without internet per se? So we need to look at the harm reduction model as a primary model per se. I'll just first summarize how this approach has to be from the clinic, how we approach. I'll talk about it. Like majority of the time with these clients, the younger lot goes with creation of rapport, because 60 to 70% of the time when they are being brought in the hospital, it is very difficult to create a rapport with them, because either it is against their thing, or some major problem would have happened and they have to be dragged to a clinic per se. So it is they come with a very negative mood to start with. So it's worth to spend time to create rapport with them. Only when we create rapport with them, we will be able to move on to do some interventions with them. Like, so it is most difficult, but it is the most important. And if we create a good rapport, I think 50% of the intervention should be over by then. And in the traditional approach that we should be able to create rapport in one session, but here it may not be possible. We need to do it multiple sessions. How do we do that? Again, the traditional approach of non-judgmental approach, and actively listening to them, what they are going to say, not being defensive about the whole issue. And since the family would come with a lot of pressure, and you also understand that significant amount of dysfunctions are noted over there, there is an urgency from our side also to intervene and change things. And if we push things, then they just move back and they don't cooperate. So we should not feel urged to change the behavior and intervene in a shorter run, because this is going to be a long-term problem. Many a times being honest work, because the kind of internet games which they do, and the kind of usages which they come, like for example, one of the girl whom we had treated some 4-5 years back, she had introduced me to the concept of this Facebook role plays and how it happens over there. Like I didn't even know what is that at that point of time. I think 6-7 years back. Now we need to be honest when we honestly asking them what is this, how they are doing. Like they are very happy, because there is the role reversal happen, and it feeds into their feeling that okay, someone is willing to listen to me, someone is approaching it in different way. So being honest work. And it also feeds into their own narcissism, so that they can open up. this is good for the first session, but subsequent sessions, we really need to be updated about what they have said to us. We may have to go back and do the literature. When they come back, we should have an equal level of knowledge, at least. Otherwise, they will not, the whole therapy will not take forward. In the assessment, I'll come into details that like it has to be a holistic assessment, and it should include an entire lot of the person's own vulnerabilities and what kind of psychopathology and what kind of consequences they have, it will lead on to. I'll not go into details because I'll come back later on this. And the treatment part is going to be enhancing the motivation for them to reduce the usage and use it more on essential part and reducing their recreational usage. And it also, the whole treatment has to be tailored for the patient's need. Each patient is very different over here, and their own comorbidity profile and the pattern of their usage need to be understood, and we need to work with them. So handling vulnerabilities, treating comorbidities, and also focusing on alternate pleasures need to be brought in. These are the basic principles, the 3 slides which I have put in. These are the basic principles in approaching the internet addiction issue at large. I'm going to focus more on the gaming disorder because that has a better literature than anything else. So we can discuss later if there are any other issues comes up. So to start with, assessment of internet addiction, I generally follow this rule that an assessment has to be, when people are being brought to our clinic, what is more evident is the psychopathology of the addiction, the addictive patterns that gets more prominence. What is the tipping point for them to reach to the hospital is about the consequences and complications which has happened because of that particular behavior. But so we are used to assess the psychopathology, and we are used to assess the consequences also because that's the reason why they had come up. But what is more important also is what made this person vulnerable to move into this whole addictive behavior per se. So if we are to do a formulation of this patient, it would be very interesting to look at in this fashion. Okay, this is a person with certain set of vulnerability, and this vulnerability led on to creation of such kind of psychopathology, and this psychopathology being there in this person has created certain level of consequences and complications in different areas of their life. The vulnerabilities again are 2 types. One is on the biological side, another is on the environmental side. We can go into the details of it a little later. And the psychopathology would be the internet gaming issue itself and all the other comorbid psychopathologies also, and the consequences because of the use of internet gaming excessively, what happens to them, how they lock themselves up, how they don't eat or eat excessively, how their whole skills getting affected, and how their academics are getting significantly affected. All these things would become the consequences part of it. So when we do the assessment and when we formulate in our mind, if we have this way of looking at it, like say start with vulnerability and then looking at the psychopathology, how it has developed, and the consequences how later had come up, it will give us a fair idea about the holistic nature of the problem itself. In terms of the internet gaming and in the internet gaming disorder, what are we going to assess is very important. And I'll also tell why is it important to assess each of this. One of the major things which we have found very interesting is that the kind of sites they go into, the kind of games they go into are very reflective of their own inner self. And a lot of things in terms of their temperament will determine what kind of games they play. Not everybody is interested in everything. They have a very specific interest in particular set of games, and then they are very loyal to those games per se. And why is that is happening? Because that serves a purpose for them. So we really need to understand what is the type of what happens within the internet when they are being brought to us. Like say he's been on the gadget all the time. Now we really need to know everything what they are doing within that hour or whatever number of hours they are with the gadget, what they are doing within that, and how much time they are using it, and what is the how they are using it, like whether they're using it in mobile or console or in their laptop, how they are using this. It will also help us in understanding how we intervene later part. As in traditional substance use disorder, here also it's more important in terms of how this whole maladaptive way of using internet has developed and how's it maintained, what the factors which are allowing them to maintain such behavior is also need to be looked for. Many times it would be the fear of failure, the fear of not able to engage with their own colleagues, or the real life is very difficult for them. So there could be a lot of this. So these issues need to be sorted out, because this will be very useful when we start doing the therapy part of it. What is the positive expectancy which the person is having towards this particular behavior or using this particular game? Because that will allow us to understand what function or what is the role which this one serves. Next is moving on to if they quit earlier, what is their reason for abstinence and how they move into it. All these things. This is traditional substance use disorder assessment, right? And what is their current motivation? And what are the things which needs to be addressed on an immediate basis? This is in terms of the psychopathology related. Now, when I talked about internet addiction criteria as such, this is Mark Griffith is one of the prominent researcher in the area of internet addiction as such. I mean, you can see a lot of, now Kimberly Young has moved out and Griffith has a maximum number of publications on internet addiction per se. He has proposed this hypothesis of components model of addiction. And in the components model of addiction, he has given this thing. And this is self-explanatory. Salience is added, mood modification is added, tolerance is there, withdrawal symptoms are there, the conflict, the intra or interpersonal conflicts which is arising out of the internet usage, and the relapse. These have been added as a criteria to develop to name someone as having a behavioral addiction. One of the great critique of this whole internet addiction criteria which was given by Griffith is that the loss of control didn't gain prominence, and that's something is not acceptable to many other researchers. And there's a lot of debate which goes back and forth on why he has. Finally, he said that the loss of control could be subsumed under the conflict itself, the intrapersonal conflict itself. But not having loss of control had become a major issue with this construct. Now, we all know that DSM-5 had brought in this, the 9 criteria, which is on not on the main DSM listing. This is on the research section of it, and this 5 criteria out of 9, if it is satisfying, then they can be called as having IGD. This is it's a more of investigatory purpose. It's not gained the entry into the whole DSM-5 itself. The assessment of non-addiction-related psychopathology, it could be loneliness which the person going through. There is a sensation seeking which the person has. What is the perceived level of stress in this person which could have contributed? Like how much amount of self-control or self-regulation which this person has. And this is concept of experiential avoidance, where what happens is, in a way to self-regulate, one avoids certain negative stimuli and use these aspect as use the behavioral addiction, whatever is the kind of behavioral addiction, for coping up with this the painful stimuli which is coming to their mind. High-risk behavior, one of the things which has been noted is the risk of deliberate self-harm and suicide are very high in this population too, and that needs to be meticulously assessed in this group. And the functionality part of it, which needs to be detailedly documented, and that will also help for the patient also to systematically look at their functionality, which may increase our rapport with this person. Complications, I don't need to go into the details of it. Physical complications in terms of strain injuries, vision issues, and posture and musculoskeletal issues which happens to them, and the withdrawals in terms of irritability and low mood, not motivated with things, and depression, all the kind of complications they go through. The comorbidity is something, there are two disorders that have been very commonly noted with internet addiction. One is ADHD and other is depression. There's a whole host of other disorders also have been seen as comorbid with internet addiction, but ADHD and depression are seemingly at a higher thing. And those who have this comorbidity, their kind of gaming which they do are very, very specific and within their own interest. And medical comorbidity in terms of obesity, the other non-communicable diseases, hypertension, and they are more prone for it because they sedentary lifestyle, vision deficits, and chronic musculoskeletal issues they go through. The temporal sequence, if it is available, will be of use. Now, this is something which Dr. Ramakrishnan has pointed out in terms of family, how a family contributed to a psychopathology. And this is seen, it's not only in internet addiction, in host of all the problems which adolescents and youth go through in terms of addiction and other high-risk behaviors in this age group has its origin from the way the family has handled these issues, like family history of substance use and mental illness, both from the biological side and from the environmental side, how it has like parent-parent interaction, single-parent family. Most of the time, these are parental neglect happens over here, and the child doesn't have a proper interaction with the parent. That results in a lot of psychopathology, which they try to cope by getting into substance use or internet. Now, that's, other factors include the support system, how other support system, both in the immediate family and the extended family also. Now, the adverse childhood experiences which one go through in the childhood contribute significantly towards the development of the psychopathology also. Generally, the physical and emotional abuses which one go through, the sexual abuses one go through, and being a victim of traumas are very, very important to be assessed in this population per se. And this can contribute both internet addiction and the other substance use also. This part I want to push it significantly, because what we have seen is that most of them have a vulnerability in terms of temperament, and their temperament are seemingly falling between either the internalizing group or the externalizing group. Externalizing group is where their distress is most often expressed outwards, and they seem to have more deviant behaviors. Antisocial personality disorder, ADHD, conduct disorder, ODD, all comes under the externalizing spectrum of disorders. And here the emotional instability is very commonly seen, and their high novelty seeking, low harm avoidance, high reward dependence is seen in this population. And this is not specific to internet addiction. It is with other substance use also, and it has been commonly seen in this population too. These are people who go more for the shooting kind of games. And their interest is into the violent games most often. So we really need to correlate the temperament and the games which they use. Internalizing pathway or internalizing spectrum disorders include low self-esteem, depression and anxiety, and a lot of the poor communication skills. That leads them to use the internet as a mode by which they can cope and run away from the real environment, which is more difficult for them to handle because of the lack of skills and on these internalizing spectrum issues. But these two are not mutually exclusive. What happens is when people have externalizing problems like ADHD and conduct on ODD at an early age, what happens is a lot of negative feedbacks from the external environment comes, and they do develop low self-esteem and depression, anxiety also. And the same way, internalizing group of people have a reaction formation and have externalizing symptoms, which may be a little less common, but it can present. So these two are not mutually exclusive. Both can be present in this population. One other thing which is specifically found in internet addiction and internet gaming disorder group is the broad autistic phenotypic spectrum, the autistic temperament per se. They are aloof, they have very poor social skills, poor emotional recognitions, and there are stereotype behaviors in terms of interest in certain particular set of things. If this is seen, it's one of the very difficult. What we do is we find the other two temperaments initially and start treating them, but then we hit a wall and we are not able to move further, and then we go into the details of it and look at it. There are broad autistic spectrum phenotypes which are being seen in them, and they contribute towards the course and outcome of this disorder per se. Now, there are screening instruments, quite a lot of it, and it's still many screening instruments are coming up. I don't want to go into the details of it. For the temperament also, there are things. I can share the presentation so people can look at it. What are these like? So to summarize the assessment part, that we need to start from the vulnerability, both from the biology of the family history of addiction to the temperament and the environmental contribution in terms of parenting and the family pathology and the drug use environment or related environment, development of psychopathology and the consequences related to it. In the management, frankly speaking, the evidence base is inadequate. It has to be based on each person's problem and addressing each person's problem with our own in terms of managing the other disorders. Pharmacological management, these are the agents which have been tried, and there are some studies which have been there. One of the agent is methylphenidate, which has been used because the ADHD comorbidity is very high, treating the comorbidity. Bupropion has been used for the same purpose, but most often all these agents are for treating the comorbidity. By treating the comorbidity, they are expecting that this behavior also will come down. Most of our work at this point of time is about the psychosocial intervention with them. Like, as I was saying, motivation interviewing is the key of creating rapport with this person and enhancing motivation of the person to stick on to the treatment. The cognitive behavioral therapy, there is a module which is being created by Young, which talks about around 18 sessions of how we go through each and every thing. Like, I couldn't get across a manual per se, but it's fairly okay, and it is relevant to what we are talking about till now. Again, relapse prevention plan, it has to be specific for this problem, but the principles are seemingly the same as what we use for the substance abuse disorder. Abstinence violation effect, I can say that how I can relate it, because many times what we do is we do download games and keep playing it, and then we after a point we feel that like, oh, we are focusing on so much of it, and then delete it. Like, but then again it starts. When it starts, again, that creates a lot of abstinence violation effect, and then we keep doing it. Like, similar thing which at a higher order happens to these people also. Now, this is one thing which I will put more importance to, because if we are removing a person or asking a person to reduce the focus on internet, right? That's the source of entertainment or the recreation which the person had. Now, what is the alternative which we are going to create? If we don't create enough alternative, then the risk of them going back to it is very, very high. So we really need to work on the positive addiction or positive alternative behavior modules. Like, I usually use the concept of passion, where choosing something which I like and that has a value. For example, alcohol or other thing, they like it, but that doesn't have a value. But here, there could be from their past, whether there could be any positive behaviors which they like also could be elicited, and that can be added to gaming, so that instead of doing gaming alone, they will be doing this also. Family therapy is essential over here, because handling the expectancy of the family itself is very, very difficult, because they come with a lot of expectancy and they push us to see changes, but we are not having this issue. Second thing, the kids might come for the first session or second session, and they will not turn up for the from the second session or third session itself, they may not come up. So how do we handle that? How do we find surrogate therapists in terms of how do we use somebody in the family as a surrogate therapist, and they can be in touch with us so that we can suggest techniques for them to do for some period of time until the person is willing to come back to the treatment setting. So a good family work is essential for management of internet addiction per se. And this is something which I couldn't find anything in India, but there are online Gamers Anonymous which is available. And I'd say like it's called Volga, and others. Anon also was there. Now, to summarize, when it comes for treatment, it's going to be the vulnerability will be taken up later. Consequences will be addressed first. Whatever is the consequence because of the whole internet gaming or the comorbid ADHD or depression, whatever has happened, that needs to be treated first, and then the psychopathology itself could be addressed. And finally, until unless we address the vulnerability part of it, like parenting or like other issues which is going around them, we will not be able to achieve a proper improvement. So the final slides on the prevention. See, internet gaming, basically speaking their language is important. If the kid is not willing to come or in the stage of developing addiction, it would be better to one of the family member to start looking at what is this game and how do we engage with this kid. Maybe one way of doing is starting to play with the kid itself. It may be difficult, but we don't have a choice. So starting to learn the game from them, and then we can actually speak their language better, and we can set mutually acceptable rules when they understand that, okay, you also know about it. Many times when we talk about it, their attitude is that you don't know anything. You're talking about it, you don't know anything, you don't do it. But then once we start engaging with them, it would be easy. And at least to look at the different ratings which are available. Like there are ratings in US, there are ratings in European countries, Russian countries. Like wherever the app or the game is coming from, we should actually look at the rating and the age group which is being given for using these games as such. Like one other technique which we can do is allowing the kid to play with the kids who are real life friends also, so that there is some amount of interaction which could be possible. And sometimes they can be called inside the home itself and they can start playing it. So yes, the game is there, but still we can at least engage them they can talk to each other and have some kind of real life communications too. Yeah, each game manufacturer give a different set of things. Then in terms of what's the monitor brightness, how much distance need to be there, what kind of gadget needs to be used, and all these things need to be looked and discussed with the kids per se. It's also very important to say that, okay, you can game, but you also need to pursue other interests also. This is more important when somebody is starting to use this. This is better pushed in. And in this COVID time, it has become a major hit because there's no other activities other than using internet is a part of it. So many of them have suffered significantly. There's this concept of brain-based parenting. It's about connecting with people early. It's not that once the problem starts, I will jump into helping and I will say that I am a friend of my son. No, that doesn't work, right? If you start then, they wouldn't be bothered. Why is he coming now? Is there something motive is there for him to come now? So until unless we start connecting early, it won't work, right? Sometimes what happens, we should help them to make decisions in certain aspects of it, like so that you can model them. You can actually share your frontal cortex with them in terms of problem solving. Sometimes you should allow them to solve problems for you. So an interactive way of handling the kids happens over there. Like sleep is something which needs to be monitored. Sleep is very, very important. If sleep is getting affected, that means there's something wrong is going on over there. It's also good to go along with other people in the school or in the environment who have been using games and internet, so that it is good. It is easy to understand what's the problem which is going on. And again, return to basics in terms of having family meals, and if someone one believes in spirituality and religious activities, they can go for that. Exercise and outdoor things. Just because we push them to do, they won't do it. Like we also need to do it. If we model it, then it's likely that they will follow it. The neighborhood and the community also need to be involved and helping the youth by creating opportunities for them to explore. And unfortunately, what happens is right now, again with the COVID, there's no much community involvement could be possible over here. Like I'll just skip on it because these are some things which are just how to healthily use gadgets. We have prepared that as an IEC for the younger lot. In summary, different models of interventions are used on whichever clinician is interested, they create their own model. But what is more important is that what is important for the person, and we need to titrate it according to it. And involving all the stakeholders are very important. And we need to have more evidence-based interventions which should come up. Let's hope in the near future we get such a thing. To summarize, I said about how the assessment and the intervention needs to happen in what way. Yeah, just anyway. Thank you.
Thank you. Thank you both the speakers for the very comprehensive and the masterly way in which you dealt with your topics. We have almost reached our time limit, but still I think that we should take up a few questions. From my side, I think we'll ask the questions to Dr. Jayant first, and then Dr. Kandasamy after the first 5 minutes. First of all, thank you, Dr. Jayant, for the very, very comprehensive presentation. I have a personal doubt to be clarified with you. You mentioned about in the assessment part, the wearable devices to monitor a person's alcohol use, like mobile alcohol biosensors, etc. I would just like to have your comment on the ethical aspects of using such wearable devices in a person with alcohol use disorder. Just your comments.
Yeah, I think that's one of the very important areas that one needs to talk about. I think, yes, so definitely it is, where does that information actually go to? Who does that information go to, and what is it used for, which will really come about in terms of the ethical aspect. Obviously, if one is able to actually use that as a way for self-monitoring, then, I mean, so it's an individual who's actually consenting to actually utilize these devices, and then is willing to actually take it up as a way to be able to monitor his alcohol use. As we know, that helps. That is, having a feedback with regards to alcohol use is one of the important things in terms of intervention. In that sense, it would probably be ethically all right. If it is going to be about monitoring or tracking an individual without his consent, obviously it is ethically highly questionable.
Okay, thank you.
On a very good presentation to Dr. Jayant. What I like to share my view is, people, you talk about gabapentin, topiramate, baclofen and all at high doses. Our patients don't tolerate. Gabapentin and topiramate at higher dose gives sedation, cognitive impairment and other things. So what is your experience about these molecules? And again about the N-acetyl cysteine, what is your, and another aspect what I wanted to tell, most of the people with alcohol dependence syndrome, what we call, many people are depressed. How about treating depression? Because as you know, 1/3 of the alcohol patients at the end of the day commit suicide. And depression is one of the commonest comorbid, or cause. It may be cause or effect. Alcohol may be a cause or effect. What is your opinion?
Thank you, Dr. Ramakrishna. I'll take your questions one by one. So with regards to the first question, with regards to tolerability, obviously, sir, I completely agree with you. I think ultimately it is going to be based on tolerability. You're right that even in our population, we don't usually go up to the recommended doses that are mentioned. Although we like, say, for example, for topiramate, typically the doses that we use from our experiences around 150 milligrams of topiramate. So 200 to 300 mg, although that is what has been tried in many of the clinical trials, we don't typically go up to those doses. Gabapentin, again, in the individuals in whom we have tried using gabapentin, between 900 to 1200, and that's why I was saying there's a whole host of studies which point towards a range of doses which are used for gabapentin. So obviously, again, it is something which would need to be optimized. Baclofen, actually, surprisingly, while there have been a lot of concerns with regards to tolerability, we have been able to, as I said, give fairly high doses in certain individuals at least, and they are able to actually tolerate, I mean, as I said, 150 up to 150 mg of baclofen as well in certain individuals. But obviously that has to be based on a titration schedule. We don't immediately go up to those doses. Our typical doses are up to between 60 to 80, and then subsequently after that we titrate the doses up if there is inadequate response despite good compliance with medications. Now, with regards to your second question, sir, again, I think it's very important because comorbid psychiatric disorders are very, very common, and depression is one of the very common comorbid psychiatric disorders. So there are two things that one needs to mention with regards to that. If there is an independent comorbid depressive disorder along with alcohol use disorder, there is some literature which has looked into what helps with regards to that. So combination, I mean, at least based on the trials, I'm just telling you as to what is there. SSRIs seem to be helpful in that context when there is a comorbid alcohol use and depression. Now, the flip side to that is there are some studies which have looked at using SSRIs independently in people with alcohol use disorders, not necessarily with depression. I mean, so again, in the context of alcohol use disorders, depression can present in many contexts. One, as you had mentioned, is that there is a pre-existing depression which actually leads the person to take alcohol. The other is this profile wherein you have an individual with long-standing alcohol use with a lot of consequences, lot of other complications that has occurred and developed depression. And then, of course, there is those individuals who have the so-called alcohol-related mood episodes, wherein you will have depressive symptoms in the context of withdrawal or protracted withdrawal. These are the three scenarios in which we usually see them. So in individuals where there is a pre-existing depression, which we are there to suspect along with an alcohol use disorder, certainly, I think treating with an SSRI, and I think SSRIs have the best evidence. Sertraline is what has good evidence from trials. Your TCAs don't seem to have very good evidence, both in terms of efficacy as well as safety. But in other cases where you're looking at alcohol use disorders and probably depression in the context of withdrawal, there you would actually have to look at some of these other agents which we are talking about, which handle withdrawal negative effect kind of symptoms rather than just SSRIs. So,
thank you. There are some interesting questions, but I think we need to cut on certain questions. Just a brief query by Dr. Rajmohan from Calicut on the use of N-acetylcysteine. He has a specific query what is about the experience and use of N-acetylcysteine in addictions.
Okay. So specifically, although there is some literature in alcohol use disorder, we commonly use it in cannabis use disorders, and that is where there is probably, as far as in the realm of addictions, that is where there is the maximum evidence. And the doses that are used are anywhere between 1800 to 2400 milligrams of N-acetylcysteine. Usually, they are available in the form of these capsules which can be emptied out into water, and they are taken either twice a day or 3 times in a day. That is what we usually use for cannabis use disorder, and there is some preliminary evidence that it helps with reducing the number of cannabis negative urines in individuals with NAC. But again, it's fairly preliminary. There have been mixed findings with regards to that. In alcohol use disorders, it's even more preliminary. So that's what I would say. But again, there is no harm in that sense. NAC is not particularly a molecule which has any major adverse effects. So that's one thing that is okay.
Thank you. Dr. Sindhu Rajesh puts across a question with regard to the safety of newer agents in the background of liver disease, especially hepatitis B. Maybe most of these agents, most of the patients with alcohol use disorder could be having comorbid liver disease. So she wants to be clarified on that.
So baclofen is safe, gabapentin is safe, ondansetron is safe. With regards to, and like traditionally we know that we don't give naltrexone and nalmefene. Nalmefene is relatively more liver safe. And what are the other agents that... yeah, camprosate, of course, is something that we use, I mean, amongst the classical agents. So,
okay, thank you.
Gabapentin are both safe.
Yeah, thank you. That clarifies that. Dr. Vidhu, are you moving on to, can we move on to Dr. Kandasamy's topic? Are there any questions pending from? Okay, so there has been very interesting questions. Dr. Kandasamy has made a very difficult, very tough topic, very lucid, and a lot of clarity has come out after listening to you. A lot of participants have appreciated in the chat box. A few specific questions, mostly some of them comments. Dr. Manik Singh asked Dr. Kandasamy whether we should be continuing to use the term internet addiction disorder. Why not we change over to a less problematic term like problematic internet use rather than internet use disorder? So that is one question coming from Dr. Manik Singh. Your comments on that?
Sir, again, this is a term, internet gaming disorder is the term which is being used by DSM-5. Before that, like this PIU was there. IGD is which they are using currently. Earlier, it should be it was PIU. There are so many names which people keep using it. Personally, I don't feel that it's a problem in naming in any of these names. What is if you ask, I think there was one other question in terms of experience in treating internet addiction. Maybe Jan can correct me. Most of the clients whom we had seen over in this place had one or other comorbidity with them, and all of them have temperamental issues definitely, yeah. But they primarily have other comorbid issue also. So it's more important to handle things as whole. Any of this terminology, it's only for us to communicate to each other. I think it's also about the lobbying which happens in the WHO and in the DSM-5 group meetings, where what terms need to be used. Otherwise, it doesn't make much difference as such.
Thank you, Dr. Rajkumari Linthosina. I don't know whether I got the name correct. She is asking whether how often, or the relationship between the musculoskeletal problems and the visual problems and the internet addiction. How often you come across, and could there be a relationship?
Sir, it definitely is a problem as such, and that too in this group, in terms of how long one is looking at the, in terms of ophthalmological, it is how long one look at the monitor, at how much distance they look at the monitor. It matters, and whether it is mobile or it is laptop or it is desktop, there are clear-cut directions about how much. Say 30, 40 and 50 centimeters have been suggested for mobile, laptop and desktop. This is a larger, but many of even us also, we do have it quite nearer, and that ophthalmologically is a problem which will eventually happen. And the blinking, the number of blinks are very less over here. So the dryness of the eye, which happens quite often, and that results in this whole computer vision syndrome and the redness which happens to them. Now, all these things could be avoided if there is a break in the work or whatever we are doing, and we can have a gap of every 20 to 30 minutes. Having a gap would be good. In terms of musculoskeletal, again, the posture is a problem. Now, many a times when we work with laptops and desktops, that's not at the vision level. We are allowed to bend, and our spine is taking a different toll. I forgot to put that. how we started from a monkey and moved again towards bending the spine now in terms of looking at our mobile. So that leads on to a lot of musculoskeletal issues, and there are quite a few guidelines in terms of what you should do, what kind of stretches you should do once you sit in the same place for a long period of time, in terms of sitting in especially in the IT industries, what kind of chairs you use. All these things has been gaining importance.
Sir, my question, sir.
Yes.
Sir, very good topic, and elaborated in depth about the internet addiction. My question will be, what is your success rate? How many patients have succeeded in treating and making him abstinent? Number one. Another thing, does inpatient care for a month, like how do you do for alcohol addiction or cannabis addiction? You do inpatient care. Is it worthwhile? And another thing is, we always in alcohol we are worried about relapse. What we suggest, other people should not take, in the family should not take alcohol. He should not be exposed to places where people take alcohol and other things. But the boy or the girl who is addicted to internet has to face a similar situation where the parents and other sisters are also used. So the chances of exposure again is same. So unless there is an inner motivation to come out of this addiction only, there will be a solution. This is my idea.
Definitely. So in terms of your first question, to look at the success rate as such, like as in addiction, other addictions also, it's very defined the success rate as yes or no over here. Like it's a long-term work which we do with them, and what the success rate with the client is based on what kind of comorbidity they are presenting with, and if we are able to address the comorbidity properly and start working with learning the skills which they have not learned. If it happens methodically and the patient comes to us on a regular basis, he or she trusts us and come on regular basis to us, there is I would say their problems are reduced. At least 60 to 70% of their problems are reduced, and they start living their life better. Now I can quote one of my clients whom I'd seen in 2011. Today, luckily on February 1st, he has joined MBBS, and because of his sheer persistence, and he continued to this thing. Then he shifted his motivation from. He also had a recurrent depressive disorder which was not identified. He has had parental conflicts in terms of parents separated, and his own self-esteem in terms of being obese and dark. All these things had contributed to his behavior. We started addressing one by one, and it took a long time. I would say that it took at least 3 to 4 years for working with him to find the success, and sheer persistence with the treatment, he could lead up to this day. And there are clients who haven't bothered to visit again also. Like, so this happens with all that addiction. I would say the kind of comorbidity which is there with them and their willingness to work, if you have a better model to work with them, its success rate is high. The second question is on the inpatients. Like, this is a very tricky population, sir, because younger the lot, their willingness to get admitted is very low, and because it's restrictive environment. When it is restrictive environment, their cooperation goes down. So what we do is initially we'll negotiate with them in terms of doing the outpatient treatment and how things are going. While this is happening, if we could create a better rapport with them and we can convince them, then we can go for inpatient treatment also. But again, whether it is inpatient or outpatient, the treatment has to be for a longer term. Either ways, it's based on the need we decide on it. But generally, the younger the client, let's say under 18 and thing, it's very difficult to admit with us also. The third observation, how the motivation matters. Yes, definitely, sir. Until unless the person is motivated, it's going to be very difficult. and this in this population, as I've pointed out, majority of them will come with at least 60% of them will come pre-contemplation or contemplation, and they won't be in a preparatory phase at all, and it increases the difficulty of our tasks every time. But yes, we don't have a go. But whenever they are motivated, it works very well, as you pointed out.
And I just want to have some comments, Dr. Karun. You just mentioned about the cyber sex addiction and pornography, so which is into the limelight of many children these days. Many parents come and give many dark gray area about this, and many of the extramarital affairs are more coming up with the social media usages. These are the things which have to be prominently addressed. I think from the Indian population, we have been seeing the Western culture so very often, but now in Indian population and the young adolescents with those spouses working abroad are easily having contact, and we're getting cases, a number of cases with the groups of WhatsApp group and other social media groups, and it has become a routine common cases in our clinic, in day-to-day clinic. So whether we can classify these people as like a social media internet addiction disorder or some other adjustmental disorders, we are not very much sure, right? And one more, just one comment, like for the last 1 year, all the children and most of the adolescents have been using the internet platform as one of the criteria for their educational purposes. And it is very difficult to conclude that right now we can classify all these people will classically fit into the IAD. So many of the parents, those who are visiting to me, I just tell them a simple advice is that just wait and watch till the next academic session gets opened when the school starts. So this is my personal opinion, rather than starting on any medications or any psychosocial interventions. So that will be my personal experience on that. What about your comments on this cyber sex addiction and social issues?
I would agree with you because this is something which is not new. Even when in the descriptions of different kinds of internet addiction happen, cyber porn and cyber relation issues have been prominently described. I didn't take it up because that itself takes a different turn on how do we treat them and what do we do with them. There is also this internet infidelities which you talked about. These are very I would say this accessibility and anonymity makes people to explore a lot. Now, in a society which is a little punitive and doesn't allow people to experiment or explore, they will definitely move into this. The younger lot, I would say the other problem is, even if they don't have any psychopathology, there is no clarity about how to use social media platform. Not only for the younger lot, even for the older lot also, we don't have much idea how to use it and what is the sanctity and discipline with which we respond to mails as such. Sharing their pictures, sharing their every time to time what they are doing, where they are going, and some of the kids get into trouble in terms of sharing their pictures which are half nude or nude pictures, which goes into the internet and creates lots of problem. Now, this is one thing which needs to be addressed at the school level in terms of what is the healthy way of using internet, what should be done, what should not be done, and I would one of the best intervention material which I had come across is the Hong Kong's primary education department has created a manual for both the adolescent teachers and the parents also in terms of what are the risks. And they've actually both the physical side and the psychological side and the social side, and what kind of intervention needs to be done on both sides. How one should keep oneself safe in different kinds of environment. Like say, bullying is something which happens, which you mentioned. The issues about one's own body shaming. All these things are happening over internet, and we as adults are not very much exposed to that. But in the children's mindset, it affects a lot of to a lot extent it happens as such. And these are some things which needs to be pushed in as healthy and safe internet usage behaviors had to be taught. How we are reluctant in terms of talking sexuality quite often now, but at least this is not that very difficult when compared to talking about sexuality. So it is becoming like food. So it's better that start talking about what is the do's and don'ts in terms of using internet. That will help to some extent to reduce the pathological form of usages. Pathological forms are always there and it needs to be handled. We do get quite a lot of people who come with those issues also. In terms of, sir, even your advice for them to wait and watch and be observant is a psychosocial intervention. It is important to handle them also. Many times they are anxious about certain things. Now, what do we do? The whole thing has moved into online platform. What will the kids do? They are also not to be blamed. When the children are not being watched by the teachers, they keep switching over to different windows, right? How much the teacher can look at 40 kids in a Zoom classroom? It's becoming very difficult for the teachers also. No one-on-one interaction. It's a very, very difficult time, sir. And the effect of it we might be able to see. Luckily, the long-term stability of the diagnosis of all the behavioral addiction till now reported is not that very great. This is another reason why that didn't gain more is very low. So I'm hoping that these kids who didn't have the psychopathology and had to use this stuff for learning, they would be able to get back to their normalcy if the normalcy returns. But the kids who are on the border, on the cats who were on the wall, they are at a high risk, and we may be getting a lot in the next 6 months to 1 year. We will be getting a lot of problems with them, especially once a school starts and every college start. We will be able to see a lot more problem. This is my assumption.
Okay. Now it's time to conclude. And we had two great erudite presentations from the Premier Institute and the Premier Institute in Addiction Medicine. And Dr. Jayan basically discussed the pharmacology, recent advances, starting from the established evidence-based medications to the experimental ones, which are to come during the last 10 years. And Dr. Arun actually has discussed how a client with addiction, internet addiction, should be, the assessment should be personalized, taking into developmental levels, vulnerability, etc. And how it should be individualized and personalized. And thanks to both speakers, and also I thank on behalf of me as well as my co-chairperson, to Dr. Ramakrishnan, Dr. Arun, and all the participants who had been part of this webinar. And thank you all. And over to the organizers.
Thank you.
Now it is my time to honor the two great speakers on behalf of the CME committee, YSR committee, chairpersons and IPS House Zone. It is my pleasure to honor Dr. Arun Kandasamy. Thank you, sir, for your excellent lecture. Thank you. And Dr. Jayan Mahadevan, thank you, sir. This will reach you in 2 days. Thank you so much for being so kind to us and spend your time for these two extraordinary lectures. And I think the clinicians and postgraduate students have benefited much from this topic. Over to Dr. Arvind?
Yeah, I think Dr. Dayal is not there, so I just let me conclude the session. Okay. So on behalf of IPS South Zone CME, we are organizing in a very right flow of the fourth month program, and it's been an honor to have two distinguished chairpersons from Kerala, Professor Varghese and Professor Vidhukumar, and I would like to thank the professor individually for accepting our invitation and sharing the session of today's webinar, virtual webinar. And the speakers of today's virtual webinar, I would like to thank personally to Dr. Jayant and Dr. Arun Kandasamy, who had given an elaborate explanation of two kinds of addictions on internet addiction and the alcohol addiction, the recent advances. And I would like to thank the EC members, the South Zone Committee members, my colleagues and the friends and postgraduates and other clinicians who have been viewing this virtual webinar and got benefited from this learning material. I thank you all and have a good night. Thank you very much.
Thank you. Thank you.
Thank you.
Aravind, can you hold for some 2 minutes? Has Aravind gone? Aravind, Sai Krishna. Aravind, are you there? Sai Krishna.
Given a message to him. He told me, call me in the morning tomorrow. So once he talks to me, I'll just get back to all the committee, South Zone committee members and put the issues regarding the topic and theme of the CM midterm.
Yes, sir.
Okay, so I've already given a message in the evening itself before the start of CM. He told that he will call me tomorrow morning as he has got some personal work.
Okay, sir. Okay, sir.
Okay. Okay.
What theme we can have this time, sir?
So let me have a discussion with Vishal, but he may be having something in his corner of his mind. So whatever it is, let's just define that, sir. Okay.
Okay, okay.
So we'll just give hands to the organizing team. So let them also work on that. So not everything will be taken care of the CME. CME will be side of the midterm CME organizing committee team, and in par with that, we will just come and conclude the team and speakers and chairpersons.
Okay, sir. Okay.
Okay. Okay.
Thank you. For that only, I just want.
Okay. Okay, sir. Okay. Thank you. Thank you. Okay.
Yes, sir. How are you, sir? Thank you. Thank you.
I'll get back to you once he speaks to me, sir. Okay. Don't worry.
Okay, sir. Okay.
Okay.
Sir.
Okay. Thank you. Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you, sir. Sai Krishna, another one help.
Yeah, thank you, sir.
I asked Mr. about the members who attended the AGB in Hyderabad.
Sir. Sir, it is with Dr. Minat, sir.
Yes,
Minat, sir, will forward to you, sir.
Yeah, he told that he will do it, but so far not got it.
I'll keep a reminder, sir. Tomorrow morning, I'll personally ring to him and ask him.
Sorry, Ira, sir, in this juncture, I want to ask you, since it is an online AGB, do we require all the names who attended, or it is a thing?
Yeah, we can. Everybody should join the meeting with their live membership.
So we are, at present we don't have the list of who joined, sir.
I think the treasurer will be having the list.
Yes, sir. That's what I have been asking, sir. But he told the organizer, the technical man, he will what this thing, they delete the mail and all. He's telling.
No, we should be having the updated list for the last October, last election. That's on June 2020. So that list will be there with Dr. Gangaram, and in addition to that will be the new additions later.
No, sir. About
after June.
No.
So I don't think it should be a problem.
No, in Hyderabad, the members who were present in the AGB to write the minutes of the AGB. That is.
That should have. They should have noted down the names of the participants there, and both in person as well as online.
Online, they didn't write down, sir. I am asking, and just what I remember reminded Sai Krishna to see if anything possible.
Sir, I'll speak to Dr. Minat, sir, and I'll update you, sir, tomorrow morning.
Okay. Who were physically there, I know. I remember 30 members were there, which we can name. But other 57 people, I think, joined in the virtual mode. But I don't know.
I think the organizing people will be having the recordings of that AGB minutes.
They got the recording and they sent their audio, sir. But then what the problem is, the names, beside it comes no chat. In that here only the people who attended will come. That they are not given. That is the problem.
They don't have the screenshot?
Yes. I doubt it. In memory, we can write, sir, who all participated and all we can write. But 100% I'm not sure we can do it. We'll think of it, sir.
What about the next AGP? How are you going to do for the attendance, sir?
AGB.
Yes, sir.
At the time, I will make it available, store it, everything.
Okay. Or we can make it as a Google form and ask them to first initially fill it and send it to you, sir.
Yes,
so
sir.
that you can have that documented written or mail document.
Exactly.
Okay, yeah, we can do that.
Better.
That is better. So, yes, sir. 10 days before, we can just ask them to send it to all the members of the IPS South Zone and ask them to send it so that we can get the list of the numbers who are going to get attending.
Yes,
yes, attending.
On the same day, we will again take a count on who
Can we ask them to, fill it up just at the time of joining the AGB?
Yes, sir. You can do it on the day or half day of before, sir.
on the day of AGB, we can ask them to sign.
Yes,
Before
sir,
they
yes.
join the link,
So we'll
they
make
had
it.
to, fill up the form and join.
Yes, sir. That will be better, sir. Initially, before giving it earlier, it will be better if you give it
And
on the
in the
day.
chat
Sir.
box, let them, and in the chat box also let them down the LF number.
Yes, sir. Yes, sir.
Yes, sir.
And we will take a screenshot also.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Okay, sir. Okay, sir. Thank you so
Sir,
much.
The problem with the screenshot is that most of them they use the telephone, mobile device rather than the name. That's the only problem.
Most of them are carrying only the mobile phone devices rather than the name or the photos, profile pictures. That's a problem comes, sir.
Yeah, that's
It's very difficult to track the mobile numbers, sir. Yes, sir. So we can formulate it, sir.
The best thing is just before joining the AGB.
Yes, sir.
Before they enter room, I think they form and then enter.
Yes, sir.
If we can form something like that, I think that will be better.
However, it is possible, sir. Not a problem.
And in the chat box also that.
Yes, sir. Thank you, sir. Thank you.
Thank you. Thank you, sir. Thank you. Thank you. Good night.
Thank you, sir. Good night, sir.
Okay.
Good night. Good night. Good night, Sai. Good night.
Good night, sir. Arvind, sir. Good night, sir. Ramakrishnan, sir. Ram, sir. Thank you, sir.
How is Dr. Kishan? He's not coming. He's busy.
He's fine, sir. He's fine, sir. He's busy with IMA activities, sir.
IMA. He has gone to IMA from IPS.
Yes, sir. Yeah, sir is vice president, sir. And against Vikstopati, there are a lot of rallies and programs, sir.
That's what I'm
So
telling
sir is busy.
From IPS, he has gone to IPS.
Yeah, IMA, sir.
IMA.
Yeah.
Okay, sir. Okay, sir.
Yeah. Thank you, sir.
Okay. Okay. Good night.
Thank you, sir. Good night, sir.